Hello, everyone, and welcome to today's live broadcast, Microbiology's Role in Sepsis Core Measures, presented by Dr. Donna Wolk, a System Director for Clinical and Molecular Microbiology at Geisinger. I'm Susie Valdez of LabRoots, and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots and sponsored by BD Diagnostic Systems. BD is a global medical technology company that is advancing the world of health by improving medical discovery, diagnostics, and the delivery of care. BD leads its patient and healthcare workers' safety and the technologies that enable medical research and clinical laboratories. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time during the presentation. Just click on the green Q&A button located at the lower left of the presentation window and type your questions into the box that appear on the screen. We'll answer as many questions as we have time for at the end of this presentation. Also, please notice that you'll be viewing this presentation in the slide window. To enlarge that window, just click on the screen icon located at the lower right. If you have any trouble seeing or hearing this presentation, click on the support button at the top right or use the Q&A button and let us know you're having that problem. Good news, this presentation is educational and thus offers continuing education credits. Click on the button in the bottom left-hand corner and follow the process for obtaining your credits. I'd now like to introduce our presenter, Dr. Donna Wolk. Dr. Wolk is Assistant Director for Clinical and Molecular Microbiology at Geisinger, an integrated delivery system in Pennsylvania. As a diplomate of the American Board of Medical Microbiology, Dr. Wolk's professional practice extends to the national and international level, supporting initiatives in clinical and molecular microbiology and laboratory leadership. Active in the American Society of Microbiology, among others, she is most well known for her strategic thinking and predications about new technology and its impact to patient care, as well as her work as one of 7 founding members of CDC-ASM collaboration of evidence-based laboratory medicine best practices. Dr. Wolk was selected as a clinical research scholar at the University of Arizona, and in 2012, she received the 1885 Distinguished Scholar Award, which acknowledges outstanding faculty whose research, scholarship, and creative contributions exemplify innovation, service, and success in their respective disciplines. She is the 2016 award laureate, selected by the American Society of Microbiology to receive the BD Award for Clinical Research in Microbiology. Please join me in welcoming Dr. Donna Wolk. Welcome, Dr. Wolk.
Thank you, Susie. Thanks so much. So depending on where you are in the world, good morning, good afternoon, or good evening. And, of course, happy World Sepsis Day to all of you on the line. The objectives today would be to introduce the concepts of core measures for sepsis and their impact on hospitals, review some ways that microbiology can support efforts to improve those core measures and hopefully then downstream sepsis outcomes, give examples of blood culture metrics and how they can support their organization's sepsis program, and review some simple statistics that support laboratory quality initiatives for blood culture processes. As Susie mentioned in the intro, my perspective is a regional core laboratory within a larger integrated delivery network that aspires to accountable care organization premises. And this is a picture of our core laboratory. So we cover 4 states with our health plan and hospitals and clinics within central Pennsylvania. And although my perspective may be this large integrated delivery network, I have worked in community-based hospitals, reference laboratories, government healthcare facilities, and academic medical centers in my career. So I am most happy to field questions from every level of healthcare organization that's on the line. 223 of you today, by the way, just FYI. Now we'll start out with introducing the concepts of core measures for sepsis and their impact on hospitals. The core measures began in 1999 when the Centers for Medicaid and Medicare Services and the Joint Commission began gathering information, which then led to the first issuance of core measures. These core measures are quality measures, and they are, in fact, federal regulations that are enacted under the Department of Health and Human Services. Core measure performance is based on adherence to the metrics that are set, and they are a part of the ongoing Joint Commission accreditation process when your hospital gets inspected by TJC. Satisfactory compliance is often greater than or equal to 96%, and this is a publicly reported metric. Now, the Early Management Bundle for Severe Sepsis and Septic Shock, or the SEP1, began in October 2015 when CMS and TJC launched the SEP1 measure for all Joint Commission accredited U.S. hospitals, and that's around 4,000 of us. The aim was to improve outcomes for sepsis, for example, reducing mortality, by mandating adherence to the CMS processes in the SEP1 bundle. So SEP1 is the first core measure, and by law still is the only national quality measure for the early management of sepsis and severe sepsis. It is by far the most complicated core measure. There are around 140 points of adherence, and if you don't hit them all, you lose adherence points very quickly. The evidence-based process and quality measure is the one delivered by CMS for the CMS-defined sepsis bundle, but these measures for the SEP1 are highly controversial among sepsis experts. They don't always match the sepsis definition that we in the laboratory and our EDs and ICUs are used to using, which is one of early goal-directed therapy guidelines widely used by the Surviving Sepsis Campaign and those bundles. So I want to make it clear that the sepsis bundles you're sort of used to supporting from a laboratory perspective are different than the SEP1 bundles in several ways, and so this is highly a contentious process. And you can read about the Surviving Sepsis bundles in the reference on the slide below, the critical care medicine and other guidances that describe the Surviving Sepsis Campaign bundles. So back to the SEP1 core measures. All U.S. hospitals and emergency providers are accountable for meeting the requirements of this measure. And the requirements is actually adherence and documentation of each step that is provided in the SEP1 measure. Now, measures that are not yet included include mortality and other clinical outcomes, but there is no guarantee that these will not be added on as they become more documented in the literature. There's also no guarantee that laboratory metrics revolving around rapid reporting will not be someday included in many of these guidelines as we move forward. So as sepsis becomes more and more important from a human and a financial and operational perspective, it's very important that the laboratories prepare appropriately in a proactive way. Now, enforcement of the SEP1 measure is kind of interesting. In its current form, it is under the umbrella of what's called a hospital compare scenario. So each hospital's adherence is reported, and then it's compared with other like-size hospitals and severity-matched hospitals. But the Joint Commission also carries the risk of low scores or actual non-compliance and the risk of losing Joint Commission accreditation, which we know is very important to our healthcare organizations. So that's sort of the teeth of the SEP1 core measure right now. But the door is opened, and people are alluding to the fact that future value-based purchasing scenarios will be added to the SEP1 as it evolves. And this means that Medicare and Medicaid reimbursement for sepsis cases would be directly tied to your hospital's rate of adherence to these core measures on a kind of a population-based level, but also even to the granular level of a case-by-case basis. So that would mean if a patient's case would qualify for that measure, the hospital's adherence would determine whether or not that organization would be reimbursed for that entire bucket of sepsis care, which we all know is very expensive, and so the teeth in this measure would be enormous, and the impact to our organizations could potentially be enormous. And that is why we're talking about them today, so that we can proactively be ready for whatever comes our way. Currently, these measures are available publicly on the website listed, and so there already is a current impact to reputation in the local marketplace wherever your hospital is located. And these measures are very important to our hospital leadership, and as many people have heard me say, if it's important to them, it should be important to us. So the good news, after all that bad news perhaps, is that there is a reprieve. The implementation of the Step 1 is delayed, but not indefinitely. Step 1 was scheduled to take effect in fiscal year 2017, but after feedback from EDs and physicians and hospitals, CMS has opted to delay. But there still is a need to prepare the laboratory for the revised guideline. Now, the bundle itself, the Step 1 bundle, relies on recognition of what's called severe inflammatory response syndrome, or SIRS. That means a temperature over 101 or a high or low temperature, a heart rate greater than 90, respiratory rate greater than 20, white cell count greater than 12,000 per millimeter cubed or less than 4,000, and bandemia. Now, you'll notice that the temperature can be high or low, and the white blood cell count can be high or low. This is because when SIRS hits a human being, it's because of the human being's response towards the bacterial or fungal or other pathogen antigens, and what becomes a pro-inflammatory response to upregulate the immune system to react kind of overdoes it, and then there has to be an anti-inflammatory response to kind of get people back in homeostasis. So it's what makes sepsis hard to recognize. There still is no national or international agreed upon definition of what sepsis is as a global definition, but most people do agree that SIRS is very close to what is listed here, and for the Step 1 bundle, this is what SIRS is defined as. 1 in 10 patients admitted to an ICU in the United States has or will develop severe sepsis. It involves about 3% of all hospital discharges, and the incidence is increasing. So this is a really important focus for microbiology labs around the globe. Now, the Step 1 measure definitions are listed here on the left from lowest to highest severity. Sepsis is 2 of those SIRS criteria we just talked about, plus a suspected infection in the eyes of a physician who's treating that patient. Severe sepsis is lactate of greater than 2 or an organ dysfunction. Septic shock would be severe sepsis with hypoperfusion despite fluid boluses and a lactate greater than 4. So we move from sepsis to septic shock. It moves up on the severity scale, but I do want to caution that severe sepsis is no longer a category in the surviving sepsis guidelines, which are the other definition, and so that's one of the measures that are different between Step 1. With the SSC, sepsis and severe sepsis are together. There is no such thing as severe sepsis anymore. Now, what part does the laboratory play? Well, the Step 1 measures require an all-or-nothing approach to the clock starting at the time of presentation to the ED for severe sepsis and for septic shock. And so hospitals are required within 3 hours, for example, to measure serum lactate, obtain blood cultures prior to antibiotics, and administer those antibiotics prescribed by the antimicrobial and infectious disease and critical care teams. This is where microbiology comes in the obtaining the blood cultures prior to antimicrobials. Within 6 hours, repeat serum lactate if the initial lactate is greater than 2. Now, this might not seem like that hard to do, but there's a lot of other measures in this. I'm just giving you some examples. There are a few more items as well for the initial 3 hours and 6 hour bundles for septic shock, but you get the picture. We need to focus on the blood cultures and our collaboration with phlebotomy and our antimicrobial stewardship teams. So that leads to reviewing ways that we can support efforts to improve these core measures and ultimately sepsis outcomes. Now, what can we do at the local level? Well, at our place, for the past several years, we've been auditing and mapping process flow maps about how blood cultures are ordered, what order sets are available in our hospital information center, how the sepsis bundle is triggered and how physicians and nurses are alerted, how the order goes to phlebotomy, who collect it and deliver it to the laboratory. And each of these timings is important to document and align the timings of collection and delivery and all of those things. And we've found that through these audits, we've uncovered several issues that can impact the core measures. So this is just one example. When we looked at the timing of blood culture collection in relationship to antimicrobial administration, we found that we had several that were, seemed out of range, kind of outliers. And when we investigated these, we learned that the blood cultures, for some reason, were ordered incorrectly or never released properly into the laboratory system. And so when the laboratory received them, we had to cancel them and reorder them properly. When we did so, the later time period was the time that was ported into the health information system. Therefore, it looked like all of these blood cultures were collected way after the time of antimicrobial administration, and therefore making our numbers look poor, when in fact they were actually collected at the appropriate time. Our 90th percentile for collection once the sepsis trigger is in place ranges from 1 to 3.6 minutes. So it's a very finely tuned system, and it's because of us uncovering these things that we can reliably say that our numbers match when the audits occur. It's also important to document whether it's a phlebotomist draw, a nurse draw, or even some places are using paramedics. So if somebody is being delivered by an ambulance, they're drawing blood cultures there, and the collection time then is always before the antimicrobial delivery. So that's kind of a novel idea. But and then these metrics also pertain to when you're looking at your blood culture contamination, which is also important for the hospital quality metrics. So these are just some examples. So I don't want anybody to assume that because SEP1 is delayed that it won't happen or that it won't evolve into other clinical measures. It's my opinion that laboratories should be proactive in this. We're already supporting surviving sepsis campaign measures, and it's my prediction that the evidence-based guidelines that show speed in diagnosis and antimicrobial stewardship decisions are useful and improve patient outcomes, and that some of them will eventually find their way into these bundles, whether it's surviving sepsis or SEP1. So just because it's delayed, I think now is our opportunity window to really get a handle on what we're doing in terms of blood cultures to support our organizations. And I would like to propose that there are three common buckets, I think, for our strategy surrounding actionable results that might be related to diagnosis that could be blended into these bundles in the future, and that any work you do to support the timing, the longitudinal calculation of each step of the way what happens to that blood culture bottle from order to the final result and delivery of antimicrobials and delivery of a report to a physician occur in these buckets where diagnosis supports therapy, it supports outcome evaluation, and diagnosis also supports the value that our laboratory can provide to patients and the value, therefore, that our organization can provide. So value is kind of one of those terms like love. You know, how do you define value in healthcare? It's a difficult strategy. Our system takes a population health strategy, and value is sort of driven out of its value for both the individual patient and the greater population that we serve. So defining that value is usually done by economists, and there's a very disciplined measurement that uses value towards improving processes, improving value, and driving the system forward. Values is defined as the health outcomes achieved per dollar spent. So those outcomes can be many different things, and I'll be giving you examples shortly. But in our place, we look at value as what matters most to our patients, our payers, our providers, our employees, our suppliers, and value is delivered that basically tries to unite all of those special interests into one composite, reproducible, and sustainable process. So the creation of value for patients then should determine the rewards for us in the system who are good soldiers doing this, and it is also then sort of the premise of the SEP1 core measure that if you do better and adhere to these guidelines, your outcomes will be better, and so there you should be financially rewarded for that. So there's a good reference I urge people to read by Porter in the New England Journal of Medicine called What is Value in Healthcare, and that reference is provided for you. It's a very interesting topic, something that we maybe take for granted, but is actually useful for us to document what parts the laboratory plays in improving value. So where do you start? If you haven't taken this process already, well, here's a tip about forming strategic alliances that focus on patients. So we call these multidisciplinary stakeholder teams. And as you can see, it ranges from emergency medicine and critical care through infectious disease, pharmacy, laboratory, nursing, all the way through financial systems, coding, economists, nurse educators, lab educators, our data analytics team, our C-suite, our quality systems, and our information systems. And we have two things that I've found to be very important over the lifetime of these processes since I got here in 2013, and that is champions in each of the categories. I mean, you may not find somebody in each of these buckets to play with you in the sandbox or kind of move forward, but whoever is willing to participate together, you can make changes, and that's something that resonates with people, and they really buy into once they kind of understand what the end game is, improving care for sepsis patients. The other thing that's incredibly important is having a historian for your larger team, because as the pie chart shows, each of these players, unbeknownst to you, is making changes in their processes moving forward, and if you are not collaborating with them and you're not in the same sandbox, then you have no idea. And so the last thing you want is to go present, oh, we did this from the laboratory point of view and this improved mortality, blah, 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 and you're in front of the whole C-suite and they go, oh, well, you know, ICU changed their protocol for XYZ at the same time, so how do you know this? So you really need to be dedicated to keeping an organizational history for what's going on around these core measures, because the organization is moving very fast, improving everything related to these. When you are going to assess your data or your information, one simple way I've found to document are improved processes, maybe faster time to detection, faster gram stains, faster molecular identification, is that value equals quality plus service plus outcomes over cost. So if you have an outcome, you can use that. It can be outcomes over cost. If you have a quality practice or a quality improvement, it can be quality plus outcomes. So any of those top three variables can be bucketed together to kind of show, here's the improvement and here's what it costs the laboratory. In essence, that's what you're trying to say. If I'm spending X $3,000 more on something in the laboratory, but I've just saved, that's my cost, but the financial outcome was a reduction of $3 million, well, my ratio is looking pretty good. So this is the kind of focus that I think people need to be taking. And step 2 in this is I urge everyone on the line to collaborate with the national initiatives. There is an ongoing initiative for evidence-based lab medicine practice guidelines that involves a systematic review of the literature and meta-analysis. The first publication was Clinical Reviews 2016. It was the first ever evidence-based guideline based on systematic review and meta-analysis to be published. The related links include other evidence-based websites like the Agency for Healthcare Research and Quality, the Cochrane Collaboration, and such. And so read through this. It's going to sound like another language to you when you're starting to read some of these biostatistical terms and definitions for evidence-based practice, but I guarantee you that it is the way of the future, and it is a way that laboratories can pool their resources. The things I'm describing are not very easy to do as a single site, even to make an improvement. And then if you make an improvement, maybe it's not statistically significant based on the number of patients you've assessed. But if you can pool your data with the larger laboratory community, which is the purpose of the CDC ASM collaboration, you can be part of a national data repository that maybe answers some of the questions of what the laboratory can contribute. So I urge you all to read this, get involved. This is happening in its second round right now, and as you develop data, there'll be a national call for data to contribute to the second round of this analysis, which focuses on does more rapid laboratory information actually impact downstream variables like mortality, costs, and things of that nature. And what's really unique about the EBLMPG evidence guidelines, we're all used to seeing publications of primary and secondary research. They are largely biased towards academic institutions that publish and have huge research teams and things of that nature. But the EBLMPG allows unpublished work. So even if you only have 25 patients that you've looked at, that data can be pooled. So your in-house quality improvement projects that may never get published can still provide a national part of the national guidance that then you can reap benefit from. Now, these EBLMPGs use a PICO framework in which you must describe your population, your intervention, what's your comparator method, and what outcomes are you looking for. And I referenced the Price and Christensen article in Annals of Clinical Biochem, which describes this EBLMPG process in the PICO framework. And also in the publication that I noted from January 16 in Clinical Reviews, there's what we call a study in a box, so to speak. The appendices include data variables that you might want to track in your organization for quality improvement. And I know every time it comes around to the calendar for what new quality improvement projects you want to partake, take a look at this. See if there's something that you can add to your quality improvement measures. Take one of them off that's working fine and try to tackle something that might improve your sepsis care. So that's there for your use. Okay, and third, we're going to talk about examples of blood culture metrics that you can use. I'll kind of elaborate on that study in the box and give you some hardcore examples and why they're important and why controlling for them is important. Now, your typical blood culture measures in microbiology, we have a couple of categories of best practice things that most labs monitor: collecting 2 sets of blood cultures prior to the administration of antibiotics. Your overall blood culture rates might be monitored, and based on the last ClinMicroNet survey in 2008 that we took, that the median kind of was around 9 to 11% positive. The pathogen diversity is something that you might want to monitor, specifically if you're comparing 2 periods of time, like the historic routine method and maybe after introduction of a new diagnostic, because you don't want 20% E. coli in your historical measure and 70% E. coli in your intervention measure. That will just throw off your comparison. So you want to monitor those things. People monitor the proper blood volume collection from adults, 6 to 20 mils, and also blood culture contamination, which is still currently less than 3%, but honestly, since chlorhexidine, if you're not 1% or less, then you need to be making improvements. So these are all things that we often measure in the laboratory. And this just gives you an example of how you can show your impact without knowing any statistics at all, by just doing graphs that show improvement over time. So this is a depiction of all of our different system hospitals. Not the last several are not included, but when I did this, it showed our mothership on the top in red, which we were monitoring for the longest. And then as we added hospitals to our system over time, almost every one of them started out either above the line or with wide variations. If you move down towards, the green, the blue, the orange, and then the teal color. And over time, implementation of standard phlebotomy practices, particularly in our emergency rooms, had everybody dropping towards, below 1%. We do have outliers that, at the time of this graph, have since come in, afterwards have come into compliance when we've provided phlebotomists for their emergency rooms, for example. But it can show you how history changes and how compliance to standard guidelines can drop things here in the purple. And then we finally picked up a hospital that was as good as or better than all of us with our last integration. So it's really important to substratify these, keep a hospital-to-hospital scorecard, because especially if you're going to be trying to push laboratory value as a part of these sepsis survival guidelines and things of that nature, you need to have your background data in a row. And if you're introducing rapid diagnostics, you certainly don't want to be spending money testing what would be only a blood culture contaminant, but at the time you may not know it. So you want to make sure your blood culture contamination rate is exquisitely low. And right now, we've lowered our measure to less than 2%, but almost all of our hospitals are less than 1%, and the average for our GMC reference space is 0.4 to 0.6 right now. So it can be done. It takes a lot of people and an effort and a system-wide delivery. There is also an evidence-based lab medicine practice guideline that's published and is being redone. So if you're keeping these metrics, watch out for that call for data as well with your quality improvement projects. Other key strategic blood culture monitors in microbiology that people may not think of are the order to collect time, the collect to receive, receive to incubation, your time to detection or time to positivity, collect to result, and a new one sort of emerging is this time to actionable result, the time of the gram stain, the time of the rapid diagnostic. Now, not all of these may be available to you. Many of them are able to be identified out of the BACTEC system, but it will take a combination of your lab information and possibly your hospital information system and the BACTEC or whatever other blood culture system you're using to get all these time points in place. And why is that important? Well, it's most important to have the order to actionable results sort of first in the pipeline and last out of the pipeline, and then the subsequent pharmacy time. But if you have outliers and you can't pin down what part of the process is being affected, then you're going to be at the mercy of all the changes of the in-between variables. So I urge you all to look at this. In our system, we discovered that, for instance, when we put in the gram stain, that time was recorded. It became organism 1, GPCs and clusters, let's say. Then when we knew it was Staph aureus the next day and we put that result in, we lost the time of the gram stain, and we could never get it back, no matter how much we begged or offered to pay our laboratory information system. So not all LISs are created equal, and we are, since fixing that, we do data dumps to grab that information before it gets overwritten. But that's kind of an important piece. When was the gram stain there? What pharmacy action was taken based on the gram stain? And then let's say you have a molecular method. Well, that came afterward, and then what happened with the pharmacy or the prescription? You need to be able to identify all those time periods. Other examples of operational metrics that you might look at. The bed days or length of stay. With that one, I'll caution you, if you're looking at mortality and length of stay, if you improve your mortality, sometimes your length of stay will go up, and you need to understand that dead people have no length of stay. They're gone. And the more people you save, the more people will be in your hospital. So don't let a finance or an operational person say, well, yeah, that's fine, but your length of stay went up. Your length of stay will go up. Your ICU days, likewise sometimes, your vent days. There are things called inpatient length of stay ratios, where you get your system, wherever you're at, will have an observed to expected ratio. Our vendor is Premier, and there are 5 or 6 national vendors that deliver this kind of length of stay that's morbidity matched. And the book that describes how the numbers are defined is about 6 inches tall, so I can't explain that to you per se, but every hospital has them. This is the first place I look, the O to E mortality metrics and the O to E length of stay ratios that your quality office will have. So reach out to them, get access to them. As you make changes in the laboratory, you may see changes that are developing in these ratios. Recovered costs, laboratory costs, longitudinal metrics, satisfaction scores, etc., decreased number of readmissions. These are all things that you can look at as far as proving the laboratory value or impact on these operational metrics. Antimicrobial stewardship metrics could include defined daily doses, antibiotic cost of stay, for example, antibiotic length of stay, appropriate use of antibiotics, time to targeted therapy. Your resistance rates are harder to budge in terms of your antibiogram, but over time they may budge. And so here, this listing kind of just gives you another opportunity to look at different metrics. And these are all generally reported in events per 1,000 bed days per the Antimicrobial Stewardship Program metrics. Now, clinical metrics, again, I refer back to these Premier or other vendor observed to expected metrics. You should have an observed to expected for your 30-day, 90-day, 120 all cause. You should get your MSDRG for sepsis or severe sepsis in that information. And you want to relate that to your time to diagnosis, your time to treatment. Maybe you want to look at adverse drug reactions in your population or infection-related mortality. Now, the last thing I want to talk about are metrics that can be used as a control for bias of your experiment. These are things that are harder to get. For instance, though, if you are reporting to your upper-level quality folks, you want to be able to make sure you're telling them that the sepsis severity, the MSDRG 870, 871, and 872 are similarly matched in your pre-intervention and your post-intervention cohorts. So that is your historical versus your, after the new method or the new blood culture instrument kind of data. Was the compliance with the sepsis bundle similar? Was the primary diagnosis similar? How about age, gender, weight, height ratios? These are things that can be extracted or obtained proactively with an appropriate IRB for human subjects or without if you're just doing a quality project. Are the hospital services that are treating these patients similar? This is all important things that can skew your results if you don't know that these things are maintained at a solid level while the other data variables are changing. Do you have an enriched data set? Your ICU patients are going to have a higher proportion of positives than your general patients. Is the order to collect blood culture time consistent? This is one of the reasons why we keep that metric. Blood culture contamination, volume, and all the other things we talked about. And is your data management system even the same during your period of assessments? Your sepsis coding practices during the time that you're collecting data must remain uniform. Just cross that should out and say must. There's an impact to how people code sepsis because there's no international defined guidelines. So at least in your organization, how sepsis is defined and coded should remain uniform, or that will completely skew your data. The percentage of the bundle compliance and all of these other things that we did talk about are all non-laboratory conditions, and those require external data dumps from places within your organization. This is an example for us when we standardize coding. So the red arrow, all of those phases of improvement were during a standard coding system, but look at the difference in our sepsis ratios. Actually, this is raw mortality of severe sepsis when we changed the coding. There's no way you could include the blue bar on the left in the rest of your decision making because it altered it so much. And this is true across every organization I've ever spoken with that does sepsis research. So this is a really important item, and I want to stress it. Another thing that happens is here's an example of the total sepsis alerts called in our ED since we now recently improved the sepsis alert system. If you're a laboratorian, you do not want to be collecting information at the time of this high variability. You either want to get your data for your lab interventions before all this variability or wait till it increases and then flatlines, kind of stabilizes itself, because these kind of severe seismic shifts are all reasons that your data would be skewed. So this is where the historian in your organization becomes very important. Who's switching what with sepsis, and letting everyone else know that something is happening. So luckily we knew this was happening, and we're not doing any interventions at the moment. And then finally, I want to close with some simple statistics that support the measurement of your quality and the comparison of your quality metrics around blood culture. So these examples are going to be from when we introduced the BACTEC, the BD BACTEC FS6 system and the Plus Aerobic F and Lytic 10 Anaerobic F media into our organization. And the other thing that I'll mention really quickly is that some of the statistics here may be unfamiliar to you. Don't get intimidated. This publication right here, Statistics for Method Verification, is a good reference to get started with, or buy yourself a biostatistics book. Even though this is focused on method verification, it's going to also give you some insight into how to calculate your means and your medians, how to create histograms, what's a data distribution, how to choose what statistics to use dependent on your data distribution, and other things about general experimental design. So I wrote that as a reference for folks, and I hope it's helpful for you. Several people have reached out and said it's helpful, so I even though it's not related to blood cultures, I'm still kind of giving you the reference so you can start reading into that. The first place I start when I'm looking at whether we're seeing effects is a simple eyeball of data. I just eyeball this data over time, and this actually depicts what happened with our BACTEC implementation. With our mortality, our actual or observed to expected ratio over this time period was reduced by about 40%, and it was statistically significant. But I didn't know that at the beginning. What I had was baseline data, and then we had our first sepsis educational 6-month period in 2013. We then proceeded to let a waiting period occur because to kind of hardwire the effects of the education, and then by chance we were granted money for the BACTEC system, and lo and behold, the implementation of the BACTEC in the ICU around May of 2014 substantially lowered and limited variability in our observed to expected ratios. And then we went live later with all of our inpatients, and we saw another decrease. So after I saw this trend, and you don't need to be a biostatistician to see this trend, all you need to do is have a bar chart and a calendar and bucket your categories. Then you go into each of the buckets, kind of starting with our wait time, which the education was performed and the hardwiring was taking place and not statistically different from each other, but looking at the changes in the BACTEC versus this historical information, and then taking those data points and doing statistical comparisons and graphs based on the buckets of information you have from the trend line. The other thing that you can do without much statistics is just simply look at your phenomics and eyeball them. What's your most common and most deadly blood culture infections? And in this case, we looked at a reduction in turnaround time for our BACTEC cohort, BACTEC B. Here in underline, we saw reductions in many of the turnaround times that also, gave you would not be able to claim that the lab had any impact to the mortality unless you had this associated laboratory data. So this is the second place to look into your phenomics. And in fact, we saw 50% reduction in turnaround time in our early pilot data. Now, the next thing I want to describe is the standard error of the mean. That's the average deviation of the mean as it relates to the sample size. What you normally see depicted in laboratory or other publications is a standard deviation. But because of the way sepsis, because of the way the laboratory has to do research, we kind of have to take what we get. If we had been given the capital for BACTEC any sooner than we did, we can't control when we get that money, and we can't delay it based on wanting to compare values. So you kind of have to take what you get, and your pre- and post-intervention periods don't always have the same number of data points. So the sample size is different, and this is where the standard error of the mean can help. You may have outliers in some of your patients in a sepsis data set, and if you show the standard deviation, that'll be highly skewed by these outliers. So when you're presenting graphs to go to finance or build your business case for new diagnostics, it's important to know that if you have these either outliers or different sample sizes, the standard error of the mean may be a better metric to use. And it is very similar to the standard deviation, looking at the normal kind of bell curve of your results and looking at the top and bottom 2.5% of the outliers of your metrics. And it's also important to know that whenever you use confidence intervals as a statistic, so say you have a mortality ratio in the pre-intervention and a mortality ratio which is the average of your post-intervention, you're going to want to put a level of variability around it, which is a 95% confidence interval. This is based on the standard error of the mean, again pointing out that 2.5% extreme variance and proving that you have statistical significance if your 95% confidence intervals do not overlap. That's a measure that you're 95% sure that the true population of your different means is actually different, that they're not overlapping. This assumes a normal random sample, a normal bell curve of data, and if you don't have a normal bell curve of the data that you have when you graph your results, then you kind of have to use different statistics. And for the most part, you will be using non-parametric statistics because of the outliers and the differences, the way sepsis is analyzed. But the 95% confidence interval is always a good bet, and most Excel and statistical programs give you this very easily. It's very easy to compare. If they overlap, they're not statistically different. If they don't overlap, they are statistically different. This is an example of the mean change. In cohort B, we have the implementation of the BACTEC. This was a reduced length of stay that we saw. The standard errors of the means are pictured as our error bar, and this is just a simple graph of a quasi-experimental design of pre- and post-intervention with cohort B, the implementation of the BACTEC. This is a graph of several levels of intervention, and it is here to depict the fact that, I'm going to go back one slide, the Wilcoxon rank sum is a statistic that you will use for non-parametric comparison of these two groups. But if you have more than two groups, as in this case, you're going to be using what's called a Cruxell-Wallace statistic. And here you can see that the median drops off nicely, but you see the variability of the mean. When you compare your means to your medians are the averages. Your medians are the point at which 50% of your data lies above the median and below the median. Your mean is skewed when you have outliers. So when you make bar graphs in Excel and you see this kind of wide difference between the dark blue and the dark blue of the median, the lighter teal and the teal of the median, you know you have outliers, and that is a tip-off that you need to be using non-parametric statistics. This is no time for a t-test. A t-test is for bell-shaped data, and so when you have that big of a difference, your normally distributed data in which you can use a t-test, your mean will be very close, if not equivalent, to your median. So that's how you can tell which statistic to use. And again, this is a Cruxell-Wallace analysis of direct costs. The last thing you can do without heavy-duty statistics is just a simple substratification. And in this case, we've chosen to substratify by the most severe sepsis cases and look at survivors and fatalities before and after the BACTEC. So on the right, you have the proportion of fatalities in the BACTEC is much less than the fatalities in gray in this. You have much fewer fatalities in cohort B in the gray than you do in the fatality bucket 8 and 1 in cohort A. And likewise, your survivors are opposite then. You have more survivors in the gray for the BACTEC intervention and fewer for the other blood culture system. So this is done to kind of give you a visual effect to double check your numbers. It's also done because not all of your populations may see the same drastic change. In general, we see the sicker the patients are, the more that speed helps them survive. And to that end, if someone's not that very sick and it's a community-acquired case, some of those folks get better even if they don't get antibiotics from a bacteremia. So you really kind of have to define your population, and I usually start out looking at the most severe group, because if I can't make a change in the most severe group, maybe I can make a change in the less severe group, but it's certainly a good place to start. It's always served me well to look at them first. And then finally, even simple descriptive statistics are important to do. So here's a display of the different services that treated a sepsis cohort that we were looking at, and between cohort A and cohort B. Now you could see that orthopedic surgery and OBGYN had none in cohort A. Well, if they account for 90% of your patients, then you're in trouble. But if there's only one case from each of these, then you can kind of determine that when the biostatisticians get the results that you may need their help in normalizing for changes in service. It's really not going to impact so much, and it's worth going forward. If you look at these buckets like family practice, let's say, where there's none of those in cohort B, and that accounts for 75% of your patients, you would have a problem. But if you have kind of an equal distribution of green and blue in your two cohorts among the services, and if you know that your critical care services, it accounts for, in our sense, something like 80%, and they're a direct match, down 3 from the bottom, well, then you know that, okay, this data set's coming along. Let's do the multivariate regression and things that maybe the people in the laboratory wouldn't do, but a biostatistician can do. It's kind of a gut check to make pie charts or graphs of this nature, histogram-like graphs, that can easily let you look at the proportions of what you have. So those are some simple tips for biostatistics, and in review, the SEP1 core measures are not yet finalized, but they probably will be in our future. I advise to prepare for SEP1 core measures now and continue to support Surviving Sepsis campaign. I advise fine-tuning all of your blood culture processes from all phases, pre-analytical, analytical, post-analytical, and getting that to the highest measure so that when the time comes, you've got best practices in your laboratory, and that will do nothing but help the rest of the organization. Document the laboratory impact of your blood culture interventions and practices with your new instruments or rapid technology, and do think about participating in the evidence-based lab medicine practice guidelines, and expand the way you analyze your data for your quality measures. When you're, a trend graph is nice, but it's not too hard to learn, or Google or YouTube, how to do a Wilcoxon rank sum in Excel. I mean, all these things are online, and they're pretty easy to do, and chances are your organization has some kind of biostatistical package. We use JUMP, JMP, and that's, I'm not a statistician, but it serves me very well. And then reach out to biostatisticians, economists, and others, the data analytics people who can pull the data you need to fill in the gaps for your laboratory care. So I want to thank you very much for your kind attention and patience with the technical difficulties experienced at the source, and shout out to my Geisinger Microbiology colleagues and Weiss Center for Research colleagues who I am honored to work with every day. Take any questions that you may have. Thank you very much.
Thank you so much, Dr. Wolk, for your informative presentation and for your important research. We will now start the live Q&A portion of this webinar. Again, if you have any questions you'd like to ask, please do so now. Just click on that green Q&A button at the lower left of your presentation window, Type that question into the box that appears on the screen and click the send button. We'll answer as many questions as we have time for. So let's get started with our first questions. We have a very captivating audience today. Dr. Wolk, what about emerging new diagnostics of sepsis? Are they complementary to blood culture and the sepsis core measures? And how often are the core measures getting revised and updated with improved techniques and technology? Sort of a three-part question there.
Yeah, no worries. You're spot on, Carolina, from Rutgers. They are rapid diagnostics are complementary to blood cultures. As a sidebar, they are not yet included in the sepsis core measures in terms of rapid diagnostics. The only thing that's included in the SEP1 is that percent of blood cultures collected before antibiotics. So if the focus is just SEP1 and that comes to fruition, then the only thing will be, order to collect to antibiotic delivery, and those time points being captured. So that's the first place to start. Now, the surviving sepsis bundles and sort of these premier observed to expected mortality bundles, they too, surviving sepsis campaign only talks about blood cultures being collected before antibiotics. The authors document that it's a limitation that, in terms of microbiology, because they include lactate and other chemistry and white blood cell counts and things. But in terms of microbiology, even the surviving sepsis campaign notes that it's a limitation that they don't have one laboratorian on their panel. It's the third or fourth iteration of the SSC guidelines, and there's still no laboratorian on there. I wish they would ask me, but they haven't yet, and they probably won't. But so that's the thing. Now, I can't answer how the SEP1 core measures, how often they will be revised, because they're delayed and they're not even issued yet. But I can answer that the surviving sepsis campaign guidelines get revised every 2 to 4 years. And in terms of the microbiology, the American Society of Microbiology and the CDC evidence-based lab medicine practice guidelines, they are based on a standard that where the literature gets looked at every 3 to 5 years. They must be updated. The literature must be updated, the statistics, the analysis of all the composite data. So that occurs, in the case of blood cultures, the first cycle, was published in 2016. We're already redoing them because of the number of publications on rapid diagnostics that occurred between, 2013, 14, and so we're already redoing those, and you should watch for those to be coming out. So it depends on what measure it is. And the SEP1 remains to be seen. And it's only my opinion, I want to point out, that laboratory or other clinical outcome measures will be included. But I do encourage everybody to get involved in their sepsis teams, because if you're not at the table, then you're on the menu. So the lab doesn't get the input, and they don't get to be part of the team, and that's always bad for the laboratory. I hope that answers your question.
Thank you, Dr. Wolk. We have another great question coming in from our audience member. We are creating our blood culture monitors. What is the recommended phlebotomy response from orders to collecting the blood culture? Is it 30 minutes? Is it 1 hour?
Hi, Jim. How are you doing out there in Louisville? Good question. The SEP1 core measures demand antimicrobials be delivered in 3 hours. That's a really long time period from presentation, but it's a big window to hit. So, and I'm not aware. I did check with Phlebotomy if they had any national board-certified phlebotomy guidelines for this. They do not. They have guidelines on how to collect, but not necessarily on when to collect. in our system, like I said, we are monitoring our system and just forcibly improving that. 90% of all our blood cultures are collected within 3.6 minutes of the order in Epic. So we've fine-tuned it down to the point where we can hardly fine-tune it anymore. But certainly I think, you know, within a 15 half an hour window would give them plenty of time to you know, most places can't get the antibiotics to people that quickly. Our system is pretty fine-tuned, so, and the window is 3 hours right now. They may ratchet that down in the future. Thanks for your
Thank you so much. Thank you so much, Dr. Wolk, and thank you, audience members, for your wonderful questions today. Dr. Wolk will be emailing all further questions coming in and giving those responses to audience members. I'd like to also today thank again BD Diagnostic Systems for sponsoring this important webinar, and LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through March 2018. You'll receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now, and thanks for joining us. We hope to see you again soon. Bye-bye, everyone.